Good morning. Hello. Good morning. I wanted to thank everyone for coming out today to the Office of Disease Prevention Medicine Mind the Gap seminar series with Susannah Fox. Before I turn things over to our Director of Communications, I wanted to say a bit about the Mind the Gap seminar series. This series explores a wide range of issues at the intersection of research, evidence, and clinical practice. Our hope with this series is to engage the NIH community in thought-provoking discussions to challenge what we think we know and to think critically about our role in today's research environment. We have several upcoming seminars that have been scrolling through the screen, and I encourage you to come out and support this seminar series. If you'd like more information, please go to our website at consensus.nih.gov/mindthegap for more announcements and to get on our email list. You also may see Jeanette and Kim right outside the room to get on our email list. Finally, I want to thank all of today's sponsors for helping to bring Ms. Fox to our attention and insist that she lend her considerable talents to our seminar series. Office of Disease Prevention, Office of Rare Disease Research, Office of Communications and Public Liaison, and the Office of Behavioral and Social Sciences Research. And I'm going to turn things over to Kelly.
Sorry. Good morning. I'm Kelly Marcial, Director of Communications in the Office of Disease Prevention. It's great to see you all here today, and a special welcome to those viewing online for the webcast. You're in for a real treat. Susannah Fox leads the Pew Internet and American Life Project's health research and oversees the project's digital strategy. Her recent reports, based on interview data collected in 2010, include Americans Living with Disability, Cancer 2.0, Mobile Health, PeertoPeer Healthcare, and the Social Life of Health Information. We've been excited about today for a long time. I first heard Susannah speak a few years ago at a training session in this room, actually, for the NIH communications directors. Her presentation that day was informative and thought-provoking, and from then on, I was on the lookout not just for reports on her research at Pew, but also for blog posts, video clips of other presentations she did, articles by others describing her work. Often the information she provided was of practical relevance to my work, but the aspect of her work that really kept me coming back is exactly what makes her perfect for this seminar series. As Paris mentioned, the Medicine Mind the Gap seminar series aims to bring to the NIH speakers who challenge conventional wisdom and make us question what we think we already know. Practically everything I read by or about Susannah's research either directly contradicts something I think I already know about the American public's use of the internet and social media in health, or applies these insights in new and exciting ways. It doesn't get better than that. So please join me in welcoming Susannah Fox.
Thank you so much for having me. I'm really excited to be here, and I remember that meeting 2 years ago. It was a great one. Thank you. So as you may know, the Pew Internet Project studies the social impact of the internet. The most interesting and exciting aspect of the internet that we are looking at right now is how mobile social technologies are inviting us to participate in the online world. Instead of letting information just wash over us, mobile social technologies invite us to jump in ourselves. This new zeitgeist of participation is transforming political campaigns, it's transforming the news business and the entertainment industry, and yes, it's transforming healthcare. Just like peer-to-peer file sharing transformed the music business by allowing people to share songs, peer-to-peer healthcare has the potential to transform the pursuit of health by allowing people to share advice, to share what they know about themselves. What we see is that peer-to-peer healthcare is the confluence of two powerful forces. Number one, the ancient instinct to share advice, to seek and share advice about health. Number two is our newfound ability to do so at internet speed and at internet scale. Peer-to-peer healthcare acknowledges that patients and caregivers know things about themselves, about each other, about treatments, and they want to share what they know to help other people. Technology helps to surface and organize that knowledge to make it useful for as many people as possible. I'll spend the next few minutes unpacking the data that proves this as a concept, and I'll also point out where I see some roadblocks and opportunities. Then I'll ask for your help in thinking through where this might go over the next 5 years. But first, a story from the other side of the country, Silicon Valley. The Web 2.0 Summit is an annual meeting of high-powered executives and leading thinkers. The stage backdrop last fall was this imaginary map of the online world and the territories that have been claimed by different companies. It's a whimsical representation of the so-called points of control in the battle for the network economy. Mark Zuckerberg was one of the last speakers of the event. He's the founder of Facebook. He came on stage and said, "Your map is wrong. The biggest part of the map has got to be uncharted territory. This map makes it seem like it's zero sum, but it's not. We're building value, not just taking it away from other companies." Now, I found that comment so refreshing and even idealistic. So leave aside Mark Zuckerberg's $1 billion and leave aside the cutthroat attitude of so much of Silicon Valley and think about what that statement means for you and means for all of us. Here's what I think it means. We know something important is out there, and it's big. It's potentially world-changing, and we're brave enough and idealistic enough to think that we can take advantage of it. What also struck me is that a map of the health world would be similar. For most people, it's unmapped, unfamiliar territory. As Susan Sontag wrote, everyone who is born holds dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use only the good passport, sooner or later, each of us is obliged, at least for a spell, to identify ourselves as citizens of that other place. It's not surprising that when someone gets dropped into the kingdom of the sick, they grab their phones, they grab their laptops, they grab their loved ones, and they go. They go into that uncharted territory of a new diagnosis, a new treatment, a new goal to lose weight or to get their numbers under control. They consult experts, they call and search and text, they study up, they band together and form posses. Pioneers share their maps with newcomers, letting them know which clinical centers are the best for a certain condition. They post warnings. No, that treatment turns out not to work as well as we'd hoped. They post new information as they find it, sometimes valid, sometimes not. And the number one thing that people try to do to get the hell out of the kingdom of the sick. I bet everyone in this room wants to help them. I bet everyone in this room is working on something that you hope will change lives, that you hope will build value. And when you're working in healthcare, your goal is not just building monetary value, but hopefully societal value. We're all on this adventure together. Whether you're a researcher, a clinician, a patient, or an entrepreneur, illness is a daunting mountain. And so, by the way, is the reform of our healthcare system. My dad was a pretty serious hiker in his day. And I remember him coming back from a particularly tough climb. He was grateful for the help that he received from the group he was with and the help that he was able to give. And he repeated the wisdom of climbers everywhere. The mountain doesn't care who you are. That's what I'm here to talk about today. How people are banding together to bushwhack their way out of the kingdom of the sick. Everyone, including the NIH, can learn from their example. We're all on this journey together, and the mountain doesn't care who you are. So I'm going to start mapping the mountain, starting with some bedrock data. This is the known world of internet use in the United States. The Pew Research Center has been tracking the uptake of internet use closely for over 10 years. And you can think of us as your GPS for navigating the online world. In order to get an accurate picture of a changing population, we conduct national random digit dial telephone surveys. We do use a mixed sample, landline and cell phone, and we survey in both English and Spanish. In 1995, only about 1 in 10 American adults had access to the internet. In 2000, it was up to about half of American adults. Now about 75% of adults and 95% of teenagers have access to the internet. Now, what's not shown on this chart is the fact that adults living with chronic disease are significantly less likely than healthy adults to have access to the internet. 62% of adults living with one or more chronic disease go online, compared with 81% of adults reporting no chronic conditions. And unfortunately, it's not just age. We controlled for all other demographic factors in looking at the data on chronic disease. There's something independent in the data that shows that chronic disease has an independent effect on someone's likelihood to have internet access. So that's one of the roadblocks to keep in mind as we look at this. There's still pockets of people who remain offline, but many of them have what we call second-degree internet access. Their loved ones are online. People who are caring for them are likely to be online. Caregivers represent an opportunity for the engagement of our elders and other people who remain offline. 6 in 10 US adults go online wirelessly with a laptop, mobile device, or tablet. What's incredible to me is that 18 to 29-year-old column, 84% of 18 to 29-year-olds go online wirelessly. And I have 3 key points about the wireless opportunity. The first one is local. Nearly half of American adults, 47%, report that they get at least some local news and information on their cell phone or tablet. This is an example of how Pew Internet's broad portfolio of research is able to benefit other industries. We're tracking the internet's impact on news, politics, gaming, education, and entertainment. The habits and behaviors that people form in those sectors are likely to port over to health when someone gets sick or is caring for a loved one. The second key point about wireless has to do with health. Wireless internet users are voracious information consumers. One example is that 48% of wireless internet users look online for information about doctors or other health professionals, compared with 31% of internet users who do not have wireless access, for example. The always-on, always-with-you internet becomes a default information source. The third point about wireless is devices. 83% of American adults have a cell phone. Small screens outnumber big screens in the United States. Ask yourself, are you doing everything you can to optimize for those small screens, to take advantage of text messaging? We recently came out with our first report focused on smartphones, a segment of that 83%. 35% of American adults have a smartphone. Our definition of a smartphone owner includes anyone who falls into either of the following 2 categories. Cell owners who say that their phone is a smartphone. Cell owners who say that their phone operates on a smartphone platform. These include iPhones and BlackBerry devices, as well as phones running the Android, Windows, or Palm operating systems. Now, one of my favorite survey questions is to ask people to tell us in their own words the one word that occurs to them when we talk about a certain topic, because it allows us to step back and let the respondents really say what they think. We asked smartphone owners to describe how they feel about their phones in a single word, and here's what they said. The 3 most common words were good, great, and convenient. However, if you look closely, you can see the word expletive, to the left of love on the slide. So there are some mixed reviews out there. Several demographic groups have higher than average levels of smartphone adoption, including the financially well-off and well-educated, which is about what you'd expect. Smartphones are expensive, as are the data plans. Those under the age of 45, and African Americans and Latinos. One of the most interesting data points to come out of this study is that 25% of smartphone owners say their phones are their main source of internet access. 25%. Fully 42% of smartphone owners between the ages of 18 and 29 say that. We looked at the data, and many of these people have other choices. They're likely to have a laptop or a desktop. They're likely to have other choices when it comes to internet access, but they choose to go online mostly using their smartphone. So here are 3 opportunities that are amplified by this rise of smartphones. Number 1, reaching African Americans, Latinos, and young people. Number 2, making place irrelevant, also known as location disabled. You can get the information out to everyone, no matter where they are. If someone is saying, I need this obscure piece of information where I am right now, I might be in a rural location, that's location disabled. The third point is that smartphones can make place extremely relevant. This again amplifies the wireless point about local, and that's otherwise known as location enabled. It can help someone in a certain place connect with local resources. So if someone somewhere is saying, where's the nearest testing center? Where's the nearest clinic? That's location enabled. And that's actually what we see driving mobile adoption in many ways. Hyper-local news and information. Previous research by the Pew Internet Project identified something we call the mobile difference. If you hand someone a smartphone, they're more likely to share, they're more likely to contribute, they're more likely to forward something, to record and upload a video, to update their status. They're more likely to participate and not just consume on the online world. And when we talk about sharing, we of course have to talk about social networking sites like Facebook. Half of American adults use social networking sites, and the vast majority have a profile on Facebook. The Pew Internet Project's recent report on social networking sites found that contrary to fears, the technology isolates people and has a detrimental impact on society. Facebook users are more trusting than other people. Facebook users have more close relationships and get more social support offline than other people. We uncovered evidence that social life online does indeed have a positive association with a healthy social life offline. We are building networks online that we tap into when we need help or advice. Slate published a story 2 weeks ago which brought this observation to life. Deborah Kopakin-Kogan's 4-year-old son, Leo, woke up on a Sunday with a rash and a fever. She took him to a clinic and while waiting for his test results, snapped a photo of him with her phone. She posted it to Facebook with the caption, "Nothing says Happy Mother's Day quite like a Sunday morning at the pediatrician's." Friends began commiserating and asking questions in the comments, which, as she writes, would have been inconceivable before she joined Facebook. In the article, she writes that she couldn't believe complete strangers would ever fret over my child's welfare. Never mind that the act of posting itself has become as integral to my daily existence as talking, writing, thinking, dreaming. Back at the clinic, the doctor gave her a prescription for penicillin, pending the final test results. But her son got worse overnight. She posted to Facebook a second picture of an even puffier Leo with the caption, "Baby getting sicker, eyes swollen shut, fever rising, penicillin not working, might be scarlet fever, or roseola, or ... sigh." After she posted a third, even more alarming photo to her profile, her social convoy shifted into high gear. A friend called her cell phone saying, "I hope you'll excuse me for butting in, but you have to get to the hospital now." Her son Max had the exact same symptoms and was hospitalized for Kawasaki disease, a rare and sometimes fatal autoimmune disorder that attacks the coronary arteries surrounding the heart. The longer you wait, this friend said, the worse the damage. To cut to the chase, the friend was right. Leo was admitted and treated for Kawasaki disease. Months later, he's still recovering from Kawasaki-triggered liver disease. And when their family doctor heard that the diagnosis came from a Facebook friend, he replied, "Bravo, Facebook." Now, this story is unusual. Looking online for health information is common. Crowdsourcing a diagnosis on Facebook is uncommon. But I bring it up as an illustration of this new phenomenon of peer-to-peer healthcare. Social network sites are an opportunity, an enabling factor in the movement toward peer-to-peer healthcare. Regina Holiday was the first person I ever heard describe Facebook as a personal health record with privacy issues. Her husband Fred used Facebook to keep his friends and family members up to date on his health, which took a turn for the worse a couple of years ago. He was finally diagnosed with kidney cancer, and looking back at his Facebook status updates, Regina saw all the warning signs in retrospect, which were missed by the doctors, who only saw him every once in a while or in the emergency room. After Fred's death, Regina became an advocate for patients' rights, especially health data rights. She's a painter here in Washington, D.C., and has used her art to draw attention to her cause. This is the painting that Regina did for me. It's on the back of one of my suit jackets. On the left, you see me giving a speech, but I'm behind a screen, the screen of impartiality and objectivity. You don't see me or my personal opinions. Instead, I feature data, and that's data on the right. Faceless, nameless, anonymized data, scrubbed clean for analysis. Light is shining in since data sheds light. But the patient is a little sad to be anonymous, to not have their story told in detail. I think about that when I'm analyzing my columns of numbers, writing reports based on data. Regina captured the tension between anonymized data and the stories that is behind each one of those numbers. You can see she even signed the painting, adult between the ages of 18 to 49. Regina has painted over 50 other jackets like mine for a project she calls the Walking Gallery. People send her a business jacket or a lab coat, and she paints a story on the back so that every time you wear it to a meeting or a conference, people are reminded to think of patients and caregivers. Because that's the point, isn't it? To bring those stories into the clinical discussions, to bring those stories into the discussions that we have about public health. Here are two more examples from the Walking Gallery. Stories of people who feel lost in the wilderness. On the left is an image showing a husband and wife who are doctors, but are now facing the wilderness of their cancer treatments. On the right is an image of a mother whose child is severely disabled, and their journey up and down the path of hospital land, where she's always a guest and never a full partner on the care team. I'll leave those images up on the screen as I talk more about how people are using every tool at their disposal to pursue health in the kingdom of the well and to navigate the kingdom of the sick. 6 in 10 U.S. adults gather health information online, but doctors, nurses, and other health professionals continue to be the first choice for most people with health concerns, especially among people living with chronic conditions. Digging deeper, we did some survey work that looked at the different kinds of information that someone might want. 9 out of 10 adults in the U.S., not just internet users, all adults, say health professionals are more helpful than fellow patients, friends, and family when it comes to getting an accurate medical diagnosis. Only 5% of American adults say that fellow patients, friends, and family are more helpful than a clinician for a diagnosis. The picture shifts when we talk about emotional support in dealing with a health issue. Fellow patients, friends, and family are the much more popular choice. And it's an even split when it comes to practical advice for coping with day-to-day health situations. Professional sources like doctors and nurses rank pretty much even with fellow patients, friends, and family. The bottom line is that the internet does not replace health professionals. Peer-to-peer healthcare is a way for people to do what they've always done, to lend an ear, to lend a hand, to lend advice, but at internet speed and at internet scale. It's the evolution of internet use that the Pew Internet Project has been tracking in other industries, and it's just finally having an impact on healthcare. For years, the default setting for most people with a health question was, I don't know, but I can try to find out. The new setting for some people now is, I know, and I want to share my knowledge. Peer-to-peer healthcare is part of that trend. Pew Internet research shows 1 in 5 internet users have gone online to find others who might have health concerns similar to theirs. Remember the mobile difference. If you hand someone a smartphone, they're more likely to share and contribute and not just consume information. We've also identified a diagnosis difference. Holding all other demographic characteristics constant, we find that having a chronic disease significantly increases an internet user's likelihood to say they both contribute and consume user-generated content related to health. They're learning from each other, not just from institutions. These two forces are coming together to drive forward this trend of peer-to-peer healthcare. On the one hand, we have the availability of social tools, and on the other hand, we have the motivation, especially among people living with chronic conditions, to connect with each other. 1 in 4 internet users living with a chronic disease has gone online to look for someone like them, a significantly higher percentage than other internet users. 1 in 4 internet users who are caring for a loved one have done so, as have internet users who have experienced a significant change in their physical health, such as weight loss or gain, pregnancy, or quitting smoking. All of these groups are also more likely to use social networking sites like Facebook to gather health information and to follow their friends' health updates on the sites. On a parallel track, people are using online resources to quantify their health. Pew Internet has found 1 in 4 internet users have tracked their weight, diet, exercise routine, or some other health indicators or symptoms online. 1 in 4 internet users. Wireless internet users are significantly more likely than other internet users to track their own health data online. The tools are in place. The culture is shifting to expect that people have access to information and to each other. There's mounting evidence that connecting patients with each other and with their data can have a positive effect on health outcomes. But we're still at the early adoption stages. What will it take to bring this to the next level? I'm going to go over the roadblocks and then the opportunities. Number 1, there are still pockets of people who are truly offline, which mostly describes people age 70 or older and those living with chronic disease or disability. Number 2, people who see no reason to change their behavior or engage in their health. They're not motivated to seek treatment, whether it's online or offline. The third roadblock is technology that's simply a pain to use, and I think we can all think of examples in our lives. The fourth is communities and tools which are silos of information, unconnected to clinical practice, and unable to connect with each other. And finally, there's a lack of awareness that online communities, information resources, and other tools exist and can help make a difference in health outcomes. Now let's go over the opportunities. To answer those pockets of people who are truly offline, which are mostly people over age 70, there are caregivers who can help someone access online resources that they may need to get better care. For those who see no reason to engage in their health, a life-changing diagnosis or other event can prompt engagement, and that can trigger the diagnosis difference. We also see mobile adoption, which really is sweeping the country. It seems to have an independent effect on people's engagement online. That's the mobile difference. Another opportunity is technology that is easy to use, that makes engagement fun and even irresistible. And finally, there's the technological means to connect silos and let data flow. Oh, and lack of awareness. There's mainstream press coverage, word of mouth, and clinical programs that can help to spread awareness. Now, this is the part in which I need your help. Think of your own lives. Think of your friends and family, or maybe yourself. Who might benefit from connecting with other people to lose weight or to move the needle on some health outcome that they're trying to do? And now think about your work, whether it's in clinical practice, research, or another pursuit. Who might benefit from understanding peer-to-peer healthcare? What are the roadblocks and opportunities that you see in the landscape? I want to hear from you in the discussion, so please start thinking about those questions. I'm going to end with some examples of beacons of change that I see. Beacon number 1, patient leaders. Catherine Calhoun is the mother of Billy, a sweet 9-year-old boy who happens to have McCune-Albright syndrome, which among other things causes severe bone pain. They live in Louisiana, but Catherine has researched and networked her way to getting Billy cared for at the best clinical centers in the country, including here at the NIH. Catherine is also a leader of a social convoy, which she describes as whip-ass patient advocates. And I can't do it in her Louisiana accent, but you'll have to just imagine that. She sends so many patients to Billy's bone doctor and endocrinologist that these doctors refer to the appointments as consults for Dr. Calhoun. She's now working on a bioethics project and recently was in a discussion group with clinicians who talked about how cutting-edge, off-label use of medications are discreetly shared among colleagues at conferences and in social settings. But what about clinicians who aren't privy to these conversations? Catherine spoke up. You hope the parents find a big-mouth, troublemaking mama like me who will give them a list of the possible medications and the whys and hows and whos. That's peer-to-peer healthcare. Beacon number 2, clinician leaders. I think clinician involvement may be a significant piece of the puzzle, a way to spark interest among people who have internet access, who are using social tools. They might have a Facebook profile, but they're not using any of that networking capability for health. And a recommendation from a clinician is powerful. Children's Hospital in Boston created a social networking software application for members of the existing 2 diabetes community, that's TU diabetes, to chart hemoglobin A1C values. The resulting tool, to analyze, allows people to contribute their own data and control who has access to it. Just to give you a sense of the scale since they launched, as of yesterday, 2,114 2 diabetes users from 61 countries have entered an A1C value on 2 Analyze. 65% of 2 Analyze users say they receive helpful information on hypoglycemia from their doctor. 72% say they receive helpful information on the topic from 2 Diabetes, the social network. And I loved this quote from one of the Children's Hospital researchers, Alyssa Weitzman. She says, "We found this very high level of what we call information altruism. People were willing, in a privacy-preserving model, to make individual decisions about how they were going to share their data. 2 Analyze opens the door between the patient social network and the clinical setting. What if that door was opened by a clinician who prescribed to analyze to her patients? Would that bring peer-to-peer healthcare to a new level? My second example of clinician leadership is the Improve Care Now network of pediatric gastroenterologists who showed how collaboration among clinicians can improve health outcomes among children and adolescents with ulcerative colitis and Crohn's disease. By sharing data and ideas, as well as building a system to support translating good ideas into practice, clinicians improved the remission rate from 49% to 67% with no new drugs. The Collaborative Chronic Care Network, otherwise known as C3N, seeks to build on Improve Care Now's success by adding patients, families, and researchers to the clinical learning system. By acknowledging the critical role that families play in keeping children healthy, C3N aims to connect the silos of knowledge that exist within the patient's home network and their clinical network. And by the way, C3N is supported by an award from the National Institute of Diabetes and Digestive and Kidney Diseases. Beacon number 3, technology leaders. These are people who make it easy and even fun to track health data and connect with other people. Patients Like Me is the aptly named service that helps people to connect with others who share their health concerns. Patients Like Me collects self-reported patient data and helps people make discoveries about how their experiences fit in with a larger picture of health and disease. If you haven't been to the site recently, it's become even more accessible, opening up to all conditions and treatments, and continuing to harness people's information altruism. This open sharing creates a way for patients to communicate with each other and with their clinicians, and it's a way for researchers to observe how conditions and treatments work in the real world. A simpler but just as revolutionary example of technology leadership is the Blue Button initiative created by the Veterans Administration. Veterans can use the VA's program, My Healthy Vet, to track their blood pressure, weight, heart rate, emergency contact information, and other health history details. The Blue Button project allows the veteran to download a simple text file that can be read, printed, or saved while maintaining control of the personal information. It's a really simple idea that's revolutionary. It's one small step for man, one giant step for data liberation. So here are my questions for you as we go into the discussion. What if all the storytelling and discussions and data sharing that we know is happening among patients and caregivers could be coded, analyzed, and harvested for insights? What if social networking data could allow public health researchers to engage in syndromic surveillance? What if, instead of running clinical trials on patients, scientists ran trials with patients? What if patients owned the fact that we have as much to share and contribute to our health as any clinician has to share and contribute? The Pew Internet Project has found that if you enable an environment in which people can share, they will. And the benefits of that sharing will entice other people. That's peer-to-peer healthcare. Thank you. So as we go into the discussion period, if you could just come up to one of the two microphones to ask a question. Does anybody have a question about any of the data? Did anybody, oh, go ahead, please. If you could come up to the microphone, please.
So it seems to me that the technology and the community are leading the patient care rather than the professionals. Do you think the federal regulation are standing in the way of sharing experiences and knowledge between patients and the professionals?
It's a great question. So are you asking about the federal regulation having to do with privacy, HIPAA? It's a very interesting question because what we see is that, for better or for worse, over the last 10 years, these patient communities have sprung up because patients want to connect with each other. And it started out on email listservs and old school bulletin board forums, and now there's really fancy sites like Inspire.com and Patients Like Me. And these exist fully outside the clinical setting, so they have nothing to do with HIPAA. They can do whatever they want, essentially. And then there are the closed systems that have sprung up in a clinical setting. And there are powerful ways that people are connecting in integrated care models. But I think in navigating that and connecting those two, that's what I'm really excited about seeing. It's true that HIPAA scares people, frankly. I think that there's also a lot of misunderstanding about how far HIPAA reaches. And so what I am always interested in is to hear from people like Devin McGraw of the Center for Democracy and Technology, who actually is able to talk about how these two worlds can be connected, even under the current HIPAA reg. And so I think moving forward, there might continue to be reevaluations of HIPAA and updates to it, but people are starting to navigate even under HIPAA. Thank you for the question.
How you doing? Thank you, Susannah. I'm wondering.
Well, we've got folks watching on the webcam, so I'm sure they're going to want to.
Yeah. Okay.
Test 1, 2.
How are we doing over here? Is this
That
sort
one's
of
on.
working? Okay. Question for you. Have you looked at all the types of medical and health interventions that are the subject of these new kinds of exchanges? And I'm talking about Western versus Eastern medicine, Western versus complementary and alternative. I don't mean versus, but
Yep.
Is there anything you can comment on regarding that aspect of it?
So whether PeertoPeer Healthcare has entered into the complementary
Are
medicine.
people that are participating in using the online wireless technologies for health information access and exchange, is that mostly within the Western medicine box, or are they going outside? Are they going to complementary and alternative? Are they going to Eastern, traditional Chinese, et cetera, or is that yet a new area that needs to be explored?
It's a great question. So the PeertoPeer Project has asked questions about whether people seek information about alternative treatments and experimental treatments. And so we do have data which looks at that, and there is always a strong minority who use the internet to look for that information. In terms of what I call the beacons of change, these are not necessarily groups that we've done survey work on, but Cure Together is one example of a patient-driven research that basically they conduct, as they put it, N-of-1 studies. And they allow people to contribute treatments for certain conditions. One of my favorite ones was on migraine. And they chart, hundreds of people contribute what helps them deal with their migraines. And then they chart in terms of whether it's popular and whether it's well known. And so I definitely recommend looking at Cure Together for an example of that. And what they find is that, sure, the medications are definitely helpful, but so are some alternative treatments. And it's in opening up that knowledge that really often happens in a social setting. You know, you go to your doctor and you get that prescription for Imitrex or whatever works for you, but you also talk to your friends about how to deal with a migraine, and that's definitely happening online. There was another hand up I saw. If you don't mind coming to the microphone, please.
Hi, my name's Martha Dawson. I work here at NIH. I've had a long career in healthcare, clear back to being 16 years of age, and I myself, over many years, have made use of peer-to-peer internet usage. For instance, when I had a retinal detachment and then had a scleral buckle, I joined a group then that was very helpful. I've also, during my career, been the privacy officer at a mental health facility. And I just want to pick up a little bit on the, not so much a HIPAA issue, but a potential pitfall for people who are using peer-to-peer internet usage. And I can use it as an example at a mental health facility where I worked that was at risk. It was a state facility at risk of being closed. Parents of adolescents, children were going to the internet to, you know, peer-to-peer, political, whatever, discuss, you know, their concerns for their child and, you know, disclosing that they, their child's identification. So my concern and my question is, you know, that information, of course, is out there, and it's going to be out there. Even when they're adults, when they're looking for jobs, maybe they want to go into politics, and all of that information, there's other sensitive information that people share. And in a time of crisis, I've done it myself. You share information that you wouldn't necessarily want to disclose. And of course, we've heard stories about Facebook and so forth. So I think that I'd put in the column of potential pitfalls that do need public awareness and public teaching of people about the sensitivity of what's out there.
Thank you so much. That's a great point. And I'll tell my own story, which is when I first started looking at this area, I met Gilles Friedman, who's the founder of acor.org, acor.org, Association of Cancer Online Resources. And he, it's very simple listserv technology for people living with cancer. And there is very intense sharing. People are willing, basically, you know, as they say, our lives are on the line, and they're willing to put their whole health history online in case somebody sees something that could trigger advice, or in case it would help someone else. And I asked Gilles when I met him, so what's your privacy policy? And he shrugged and said, our policy is that you have no privacy. And that's an example of a community that's part of the deep web. It's email listservs, they're archived, and it's password protected. And so the good news is that those 15 years of insights are part of the deep web that's not usually searchable by Google. And yet it can be surfaced. And what's really amazing to see is how our culture is changing to absorb all of this sharing. You know, not many people could have predicted that we would want to share as much as we do on social media sites, and some of us more than others. And it's a concern that I think is actually broader than healthcare, and certainly it's specific to health, but it's something that we really need to think about as a society. How are things changing to absorb all of the sharing? Once everybody is completely public, do we need to have a policy that you have no privacy? I'm not sure that makes sense. And one of the things that, that we have observed is that people in surveys express concern about privacy if you ask them questions about what they want to share. We've asked questions about what do you think is known about you online? This is not our health surveys, but our surveys about digital identity. People don't know what's actually available about them online. People don't know how findable they are. And actually, baby boomers are the most likely to be findable online because boomers are less likely, for example, than millennials to have a landline, to be at the same home address for over 10 years. Millennials are actually pretty savvy about clouding who they are online. And so we've got this disconnect between generations and between people who say, be careful, and other people who say, let the data flow. So it is a great question that I think we need to think about more deeply. Another question?
I'll take a chance with this mic. No, you have to get close to it. I do sound work. Okay. I'm a man, so I don't like to ask directions. And one of the reasons I don't like to ask directions is that in my experience, most of the time when I ask directions, the directions I get are wrong. I'm just wondering if anybody's done any outcome studies on peer-to-peer health support.
Great question. So we have not done studies just looking at peer-to-peer, but we, about every 2 years, put a survey in the field about health where we ask people about whether they or someone they know has been helped by online resources or whether they've been harmed. And the percentage of American adults who've been helped has fluctuated, but it's always between 1/3 and or more people who say they've been significantly helped by health information found online. Harmed has been a flatliner at 3%, and that's from the first time that we asked it in the year 2002, I believe. And so there are people who say that they or someone they know has been harmed by information they find online, but it's quite low. It's just 3%. There are studies, there are journals who are tracking this. The Journal of Participatory Medicine is tracking it. The Journal of Medical Internet Research is tracking these studies. And so it's definitely of use for people to start asking people about where they get the information so that we can start quantifying whether the good information or bad information is coming from online resources or offline resources. Because of course you can get bad health advice offline. But again, the internet makes it faster and it makes it a wider network than ever before, for good or for ill.
Good morning, Susannah. I have 2 questions. You talked about individuals with chronic diseases, and I was wondering if you could talk about individuals with rare diseases and how they're making use of social networks and tools. And then number 2, with respect to people using mobile, do you have any data on the types of health topics and types of information that people are searching for with mobile technology as opposed to typical desktop technology?
Thank you so much. Great questions. The study that is actually titled Peer-to-Peer Healthcare was a combination of an RDD phone survey and surveys of communities of people living with rare disease. And so what we did for that survey was ask people to tell us stories. It was not anything that we could quantify necessarily, but we got some incredible stories about people who are living with rare disease. And that's actually how I met Catherine Calhoun, who was one of the patient leaders I talked about. when I started doing the analysis of the rare disease community respondents, I have to admit that I spent quite a bit of time doing the analysis at home because I needed to cry so often. I love my colleagues, but I'm not ready to sit in my office and just let the tears flow. And that is, and what was so moving about doing that analysis is that people see the internet as a lifeline among people living with rare disease who might never have met anybody with their same condition. They can talk online with hundreds of people who have the same condition, and they're able to share really serious clinical information and scientific information. They're able to share tips about where to get treatment. Some of the incredible stories were moms of kids of babies who have digestive issues, and those moms told about how a doctor or nurse can't tell them how to position the baby to feed them better than a mom could. And so now there are not only discussion forums, but online videos where you can get information about exactly how to take care of your child or loved one. What was also incredible was to hear about how there was a certain family, and this rare condition is passed down, and they have over 100 years of knowledge about living with this rare condition, and it was passed down generation to generation. But instead of keeping that knowledge siloed in the family, they're able to share it with everyone. And so the mind almost boggles when you think about the potential of this for rare disease. They're really the superheroes of peer-to-peer healthcare, and I'm really, really inspired by them. In looking at mobile, so before I tell you what the topics are, let me describe again the people who are most likely to be using mobile. 18 to 29-year-olds. They're the most likely to have mobile access. They are the most likely to use their smartphone as their main source of information. It's the always on, always with you internet. And wow. For people on the webcast, somebody just turned on a computer and it was super loud.
Oh, that was CNN.
Well, so the topics that, and this is Yahoo data, this is not Pew Internet data, but Yahoo looked at the types of information that people look for on their mobile platform versus their web platform. Sexual health information is on the mobile platform. It was pregnancy information and STD information versus on the web, it's more of your general health concerns that you'd expect. Now, I will say I gave a talk a couple of years ago to undergraduates, and it was a big lecture hall, and frankly, most of them were not paying attention to me. They had their laptops open, and that was fine. I knew that I would reach a few of them with the data. But they were, if you can imagine, they were all heads down typing until I got to the point where I was describing how AIDS.gov did analysis of when they get the most traffic and what people are searching for. And I said, it's those middle of the night, oops, moments that people are searching for information about HIV. And all of a sudden, all 100 heads looked up at me. I suddenly had their complete attention. And that's actually a great example of a federal agency that looked at how people were arriving at AIDS.gov. They weren't looking for policy prescriptions. They were looking for basic information about HIV transmission. And so AIDS.gov was able to really change their website to respond to the public because they did come up first in a lot of the search results. Another question?
Hi. I was wondering if there's been any investigation into peer-to-peer healthcare sharing pathways in other countries around the world, especially countries that have different usage patterns in terms of wireless adoption and also larger age gaps.
Great question. There was a Health 2.0 conference last spring and in Paris, and there was representation from all over the EU and presentations made. And actually, I should say that I'm going to put the notes from what I said with links to all of the articles that I cited and all the organizations that I cited, so that if you're interested, you can dig deeper. And I'll add some links to Health 2.0 Europe, because all the videos of the presentations are up on the Health 2.0 site. Two of the countries that I look to for inspiration for where the future could go, one is Denmark, and the other is the Netherlands. Denmark is living in the future. They, I mean, let's just, get the caveats out of the way. They're a tiny country, extremely different from us. Their healthcare system is extremely different from ours. They have ubiquitous internet access and ubiquitous electronic medical records. And they do, in fact, have clinical integration. But both Denmark and the Netherlands, which is similar, frankly, in terms of their healthcare system and the size of their country and the way that they're integrated with the clinical setting, both of those countries came to the conference and even then followed up with visits to the United States, because the US is ahead in terms of that individualistic American spirit of, I'm going to help myself. I'm going to connect with other patients. And so that's what I'm really interested in looking at, the difference between, let's say, the European model, where it's the resources for healthcare are very different than they are here, whereas in the United States, there is this sense of, empowerment and, sort of up with patients that is happening in Europe, but not to the same degree. And so those are the two places that I know the most, and I'd be really interested if other people have observations or a more international perspective on that.
Hi.
Hello.
Bob Gold. Just want to add a little bit, and that is that in African and Indian areas, substantial use of mobile technologies currently in use, as you know, but really more population-based applications. Trying to deal with delivering services in remote and rural areas, it takes on a different focus than the individual reaching out for assistance. It's really a system delivering assistance to larger groups of people. And the recent UN publication on mobile technologies and development is something that everybody ought to read about, because UN just completed a 92-nation survey regarding the utilization of mobile technologies for health.
Yep, and I actually thought about, when I had the slide about small screens outnumber big screens, we just look at the US, but clearly that's the case in Asia, Africa, India, et cetera.
I wanted to go back to your closing statement about doing clinical trials with patients instead of, I think you said on patients.
And that's a line I stole, so.
I was just curious. I mean, I certainly see the benefits of patients interacting and sharing information, but when you're in a clinical trial, I'm wondering if there's some possible detriment to people sharing information and trying to figure out if they're on the standard treatment or the experimental treatment, and then maybe, reaching out for some, alternative treatments because they think they're on the experimental one and it's not working, or even on the standard one and it's not working. And I wondered if you had any insights into that.
It's a fantastic question. So we have not done studies looking at that directly, but what I can say from doing field work in patient communities over the last 10 years, one of the first insights that we got from field work that we did in a patient community is someone who said, we're like lab rats tapping on the bars of our cages. And the lesson that I take from it is that people have always talked with each other if they can. I remember hearing about one clinical setting where patients would arrive early for their appointments just to get a chance to see someone else who had the same condition. And now they can do that online. And it really can be a double-edged sword because, of course, one of the major challenges with clinical trials is recruitment. And so, you know, you have the opportunity where people with rare conditions or people with chronic conditions, or if people know about the Army of Women, where people are recruited into breast cancer trials, here's an opportunity where the network is doing your recruitment. And there's something really, really powerful about that. And you know, is it just something that researchers are going to have to get used to? Possibly. Is there a downside to it? Possibly. And is there a benefit to it? Possibly. And so one of the things that again, I rely on is that I sometimes call myself an internet geologist, because what I can do for you is tell you sort of where the landscape is and where I see an earthquake coming. And I can't tell you what to do about it, but I can tell you that it's coming. And so that's what I would say about the clinical trials challenge, that we have patients who are deeply interested in contributing. There's not only information altruism, there's true altruism in giving up what you can for the betterment of society and the betterment of science. And, you know, what can we give back to the patients?
Hi, I work at NIH, and I'm also a cystic fibrosis patient here at NIH. And for me, the peer-to-peer landscape has been fantastic because in my condition, we're not supposed to get close to each other and meet up very frequently to talk. So the CF community online is very vibrant, and I was wondering if there's any evidence in your work that the rare symptoms or problems that are being discussed online are indeed making their way into clinical research and trials, and if not, how in the patient community can we get there, and if there's anyone who has power. Casein intolerance in CF, I think, is a real problem that has not been studied.
Thank you very much. And that is a great point. Yeah, CF is one of those that is really perfect for internet communities. So one of I've seen examples where people are starting to look at patient networks. And what's really heartening is to see that this is happening in the .com world. There's a lot of interest in the .com world. And there's also a lot of interest in our world here in DC in terms of .gov, as well as in .org. So I think that I'd actually be really interested in doing a literature review to see what has been done so far and what we have learned, because I know of some studies, but I think that it would actually be very, very useful. And if somebody knows about such a literature review that's already been done, please let me know. It would be really useful to bring together what's been done so far as an example for other patient communities. I do know that the Life Raft community actually is one example in the cancer world who, through the advocacy of patient community, was able to push forward a pharmaceutical company's development of what turned out to be Gleevec. And so that's one of those sort of rallying stories for a lot of patient communities that there is the opportunity to say, and this was, by the way, a very, very small clinical trial, and the patient, this happened more than 10 years ago, it was a very small clinical trial that showed such promise, and yet the pharmaceutical company was going to abandon the drug for various reasons. And I'll link to the article that shows this. It's told in, a link to it in Cancer 2.0. And they were able to successfully lobby for this drug to go forward. And this certain kind of cancer is now essentially a chronic condition, as long as they stay on the drug. Yes.
Hi, I'm working on an outreach campaign to family caregivers. And I was wondering if, when you're looking at information sharing, if you're making a distinction or what you might have to add about the distinction between the types of information shared that is condition-specific, and then the types of information that sort of spans conditions. Like in my research with caregivers, some of the things that come up are like wound care, very important, discharge planning, home care, and also medication management. And so I was wondering if you had anything to add about the differences, and if you've tracked that.
Yeah, great question. So we have an ever-changing list of topics that we ask people about and ask whether they have gone online to look for information about those topics. And we have added some things like long-term planning and end-of-life care, and the most recent health report, The Social Life of Health Information, has some summary charts, and Health Topics also has some summary charts of all the questions that we've asked over the years. And actually, I usually crowdsource that list by asking people, especially on the ePatients.net blog, to suggest topics. That's actually where I got the end-of-life care topic to be added to the 2010 survey. So I invite people actually to email me suggestions, and I'd be really interested to hear what topics are we missing from the list. And I'm actually really, really interested in doing a special caregivers report. We have tons and tons of data because we have asked that caregiver question. And so if you want to talk afterwards, I would be happy to provide more data. Hi.
Hi, Susannah. Stephanie Daly, work on the NIH Senior Health website. Thank you so much for that wonderful presentation and for those insights. I have a question relating to older adults. One of the things that you said during your presentation was that people with chronic conditions seem to use social media a lot, yet older adults have a lot of chronic conditions, but they don't seem to be heavy users of it. Could you say more about that, why you think some of the reasons are, and if there are any reasons, any ways that you see that changing? And the second corollary question is, right now, boomers have moved into the over 60 category, so they're now older adults, and yet they're different from people who are 70 and older and 80 and older. Could you say something about the differences you find in peer-to-peer usage, peer-to-peer interaction between boomers and older adults?
Absolutely. Thank you so much for that question. Yes, boomers are transforming the senior demographic from the bottom up. We see this wave of internet access. If you look at the age groups in a cliff, now it's moving up. A couple years ago, I would say definitely age 70, and it's really moving up, to 72, 73, and folks who are offline. The baby boomer wave is really transforming that population, but we still have a hard core of people who are truly offline, who are in their late 70s, 80s, 90s. What's an opportunity is that it's really interesting. A lot of these folks have cell phones, and these might not be people who are using them for text messaging, but if there's some application that can be, a voice-activated call-in service, then that's the kind of thing that the cell phone is able to do. And I often say, don't forget to make it easy to print out, because that sneaker net is still a network effect. Sneaker net meaning that you'd actually have to get up and walk your disk over to the printer. I don't know if anybody remembers that from way back when. In terms of the use of social media for health, it's a really important caveat to say that once someone is online and they have a chronic condition, that's when the diagnosis difference kicks in. And it's that once someone is online, which is always why I lead at the beginning with the fact that only 62% of people living with chronic conditions has access to the internet. And so looking ahead, sort of 5 years from now, we're going to continue to see that demographic change, the demographic shift happening. But once someone is online, age becomes less of a factor, especially with chronic conditions. And this is also where we see the changes happening in other sectors porting over to health. There are lots of seniors who joined Facebook to be able to see pictures of their grandchildren. How can that be leveraged for health? Or do we want it to be? Or do we want something different to happen? So those are the sorts of things that it's important to look at, not just our health data, but the broad portfolio of what older Americans are doing online. We have a series of reports called Generations Online, which could be very useful. Yes?
Hi, Kathy Camp. Thank you. That was an excellent discussion. My question has to do to get back to some of the outcome issues that were brought up by the gentleman up in the front row. Is there data that peer-to-peer health exchange actually delays people from seeking health care from a healthcare professional? Number one, and number two, have you accumulated or asked healthcare professionals what their perceptions are regarding risks and benefits of peer-to-peer exchange?
Great questions. We have a challenge in doing telephone surveys that we can't get the details. That's the anonymized data that we have. One way that we try to get around that or try to account for that is to ask people about the last time they needed health information. In a survey, it helps them to remember something very specific. And so we ask them the last time you had a significant health question, who did you turn to? The overwhelming majority turned to a health professional. And we actually see that cutting across whether someone has health insurance or not. People really do want to talk with a health professional when they need a diagnosis and when they have a significant question. And so we don't have evidence either way about whether they delay treatment. And that would be a very interesting question to ask. And in regards to clinicians, the Pew Internet Project focuses on general population consumer surveys. We have not done surveys of clinicians. There are organizations who have, Manhattan Research, I believe Forrester Research has done so. I think it actually would be really interesting to ask some of these social impact questions of clinicians, because very often since the organizations that are doing the clinician research are for-profit entities, they have a different orientation than a nonprofit entity. And I think actually it would be wonderful to ask some of those questions. Frankly, we don't have the budget. Clinicians often want to be paid for their time in doing surveys.
I think that for most part, people want to share their experiences and seek for information. One of the issues is that the fear for the consequences once they're being identified, whether in the community they will be labeled or be denied some insurance, or in the workplace. So assuring the patient or the individual that there's no, he doesn't have to fear, it helps. And I think that the fear is, the degree of fear is depending on who you're talking to, what community, And among the rare disease community, as you realize yourself, that fear is less acute, and they actually don't want to be anonymized. They want to be out there so people will know them. So I think education and regulation to protect any consequences from being identified can relieve the health sharing more and information between others.
Thank you very much. So that would be a vote for regulation as an opportunity and education as an opportunity for that roadblock of that fear of engagement. Thank you.
I wanted to follow up on the question that was asked a couple questions ago about the different age categories. And, since we have so many communicators in the room and online, it's a question of resources. If we've got the 18 to 29-year-olds who, according to your incidental data, are most interested in sex, and the caregiver...
On their mobile phones.
The caregiver population for many chronic conditions, certainly not all, and I'm not trying to put everybody in the same basket, but several chronic conditions are of the older population, so the caregivers would likely be the parents of those 18 to 29-year-olds. And certainly the people with chronic conditions fall more into that category of not using. We know that they disproportionately affect African Americans and Latinos, and they have less access to information. So I'm wondering if you had any thoughts or recommendations or regarding where government communicators should be putting their emphasis. Is it to reach the ones who are already sold on the technology, or is it to reach out to those who may not have as much access?
Great question, and it actually, that was one of the major questions at a conference I attended, the Mobile Health 2011 conference at Stanford, which was a mix of people who were there from Silicon Valley, because it was held at Stanford, and actually a lot of people who were from the federal government. Was anybody here at Mobile Health 2011 by any chance? There were some folks from the NIH at the conference. And there were also people from state public health agencies. And it was really a tension, frankly, in the room and on stage, because there was a lot of excitement, and there continues to be a lot of excitement about mobile apps. Those iPhone apps or iPad apps. And what I often do is I go back and I look at the numbers and say, gosh, it's only 1/3 of American adults who have smartphones, and it's only 1 in 10. It's a very small slice that have these tablet computers. So I don't know, who are you reaching with these apps? Sure, get excited about the apps, but the people who were focused on public health, whether it's at the state level or at the federal level, were talking to each other and also on stage about how it's not about apps, it's about optimizing for the mobile web. And somebody else had the insight that, sometimes you don't have the budget for an app. Sometimes it's difficult to get something changed. You have to go through quite a few checkoffs to get something published online if you're part of a state or federal agency. But so much of the health information that people really need is really stable. And so therefore optimizing, freeing your information from the PDF and allowing it to be shared, allowing somebody to be able to blog something or grab an image, that's what a lot of the public health folks were really focusing on, whereas the entrepreneurs were very much focusing on the apps. Yes.
Hi, Bob Gold again. I have two questions, and feel free to pick or choose. The first one is a follow-up to something you just said, actually, coincidentally. There's a problem with permanence of information on the internet. And the best illustration I can think of is that early in the last decade, the FDA released some recommendations related to listeria for women who were pregnant about what foods to avoid and what foods not to have to worry about. About 6 years later, they revised those recommendations, but the original recommendations never can be removed from the web. And so the challenge from a public health perspective is, what do you do with information once it's permanent, even though the science changes in this environment? And I don't know if anyone's really systematically looking at that issue as a public health issue, but it's one that we probably ought to be concerned about, because there's no guarantee which of those two sets of recommendations someone's going to find. The other question has to do with tools. I appreciate that you're a geologist of the internet, and that really is my primary interest. Since the release of Healthy People 2020 last November, I've collected every tweet about Healthy People 2020 into a private archive. And I'm looking for tools that can help me organize that information in a meaningful way and extract useful ways in which people are applying it, the challenges they have, the benefits they get from it. And I just want your thinking about that.
Great questions. Regarding the permanence of information, it's definitely a challenge. I think that we have some librarians in the room who would be wonderful respondents to that question, probably better than me, in terms of how to create information architecture and archives that would privilege the more up-to-date information. I think that, I don't know of a study, but I bet there has been one in terms of looking at the search results, because it's still true that most people are using a search engine when they have a health question. So it's sort of the stages that people go to when they get a new diagnosis. They go online to recover from the doctor's appointment. They probably punch some keywords into a search engine. And then when they dig deeper, they get into stuff like peer-to-peer healthcare. But what about that first stage? What do they find when they search? I actually recently read a book called The Panic Virus, which is about vaccines and the spurious link to autism. And it's a book by Seth Manookin, which dug really, really deeply into the dangers of online health information and how it can, you can go down a rabbit hole where everybody is saying one thing and it's divorced from the reality of science. But it becomes that echo chamber that you fear. And gosh, that Lancet article, I mean, by the way, hello, smoking gun, Lancet? Anyway, but it's something that I think that we can look at and that I'd actually be really interested in talking to the major search engines about, because the way, it's a black box about how Bing and Google and Ask and Yahoo choose the algorithm. But you can pretty much tell, how, when they change things, what's going to be privileged. And so as long as sites like the NIH and PubMed and CDC, all of those still pop up high, then that's an indication that we're on the right track. But it would actually be very interesting to engage with the search community, as I know the NIH has engaged with Wikipedia. And your second question was the tools. So since I know you're at University of Maryland, I would recommend Ben Schneiderman. That's frankly who I would contact if I wanted to do that kind of research. Yeah.
If I can add to that, there are folks at the National Library of Medicine that are doing natural language processing, including looking at tweets and so forth, so you might want to contact them as well. On the issue of the echo chamber, so in some communities, including the autism community, NIH has actually proactively engaged them. So there is the Interactive Autism Network now that is connected up with NIH and is mitigating some of that.
Thank you. Yes, thank you.
Someone mentioned, it might have been you, the interesting concept of cost. And now in the midst of all this budget things that we've heard over the last couple weeks, has there been a whole lot that you've seen out there based on, does this increase, does use of peer-to-peer and use of the internet increase or raise the, or decrease the cost of health care?
Great question. So we don't have data that looks at that. But I will say that I'm getting more and more calls from state-level public health agencies whose budgets are being cut, who are looking for creative ways to spread the knowledge about controlling diabetes. For example, people are looking for new ways to navigate this epidemic that we have, frankly. I mean, sometimes I look at the broad public health trends, and we see this growing cohort of people living with preventable chronic disease. At the same time, we have a growing cohort of people who are online, using social media for fun, for work, for whatever, less likely to use it for health. And that's when I see that, I see this base, I sort of picture it like a giant cliff of snow, that there's this, threatening us, that we've got this huge population living with chronic disease, equally large population using social media. What's going to trigger the avalanche? What's going to trigger the avalanche, and which way is it going to go in terms of people connecting with each other to support each other in, again, getting their numbers under control, losing weight, finding treatments. And when I think about also the superheroes, the people living with rare disease, and I'm making this motion because I think of them sort of at the pinnacle of peer-to-peer healthcare. They have the greatest need, and they're rising to the challenge by networking online. What about the rest of the mountain of people who could benefit, who could learn from the superheroes of rare disease, and sort of let the lessons come down to people who have more common conditions or just need to get something under control? Sorry, I don't have data. I just have hope. Any other questions?
Hi. So I'm curious, given all of the, I guess, reliable and unreliable information that's kind of out there, have you found that providers are these days, reluctant or the reverse, very willing to tell their patients when they leave after an appointment, why don't you go to the internet and check out some information on your own? Specifically, speaking of underserved populations who maybe wouldn't think to go to the internet to find out more information. Curious about the providers.
It's that's one of those questions that I would love to ask clinicians. When we have asked the consumer general population about whether they've consulted a doctor about what they find online, people are, it's been a mixed review about whether clinicians are being encouraging or not. When we look at the general population and we see this cultural shift that's really changing political campaigns, it's changing the news business, it's changing how we get movies and music, you almost have to believe that clinicians aren't immune to the culture change. And I have been at medical conferences. I went to the American College of Surgeons last year and was part of a panel about social media use among surgeons. And I actually was frankly really nervous about that conference. I just hadn't spoken to that many surgeons, it was one of the friendliest audiences that I've ever spoken to. It was a packed, huge room in the convention center here in DC. And there was actually a Twitter tutorial being led from the stage. And the results of the tutorial were up on the screen because people were asked to send their first tweet using the hashtag. And the screen filled with all of these surgeons sending their first tweet. And so that's, not data, it's just an anecdote, but it was really interesting to see how this population who went through their entire medical education and are in practice, not having learned about this, and how eager they were to learn about how to connect with patients. And yet, most of the discussion was about the challenge of knowing whether they should friend a patient on Facebook, for example. And so that's where the beacon of change that I brought up from Children's Hospital and the partnership with 2 Diabetes is really interesting, because it's something that they acknowledge. They try to create a tool that's Facebook-like, but in terms of usability, but is professional. And so it's a way in a professional setting, not with your high school friends mixed in, but for a clinician to connect with a patient and be able to connect with the social network discussion that's happening anyway. And so I think that the culture change is reaching doctors, and I'd love to see more data to show it. Thanks for the question.
Thank you, Susannah. A question, what information are we missing? What are we not providing to the patients, the healthcare providers that we should be providing? Or is there sufficient information and we're not packaging it correctly to get it out there to the public?
That is a great question. So that's where I would point to the research where we ask people about where they turn for different sources of information. It's really, really interesting to see how, when it comes to medicine, when it comes to a diagnosis or figuring out a treatment path, people are very likely to turn to clinicians. Whereas so much of health happens outside the clinical setting. And so while in the past people may have been frustrated, they don't really know, so now they're on this treatment path, they have a diagnosis. Before that happens and during that process, they turn to a clinician. And then after it, they turn to friends and family and peer patients, unless they can't get a diagnosis. And so I think it's when we see those disconnect points where someone is more likely now to go online. And so I think it would be a really difficult question to answer, because it's different for every person. But if someone is searching for a diagnosis and unable to get it from a health professional, then what we've seen is that then triggers the likelihood to go online. Well, thank you so much. I've really enjoyed this discussion. Thank you very much for coming out.
I just want to thank everyone for coming out today. Remind you that on September 6th, in this same room from 1 to 3, Thomas Levis, the director of Hopkins Center for Health Disparities, will be here discussing health inequalities. And I don't know if the director of our office, Paul Coates, had something to say.
Thank you. Maybe it's for that. I really enjoyed this. This is a series that I have a strong interest in. I didn't invent it. It was a creation of my exceptional predecessor, Barry Kramer, and his staff. But I got to inherit this, and I think this is a wonderful start to a new series of conversations about where do we, if there are gaps, how do we address them? And then how do we try to deal with filling the information gaps? This is such a wonderful way to get started. Thank you, Susannah.
Thank you.